All right, everybody. Thank you so much for being here. I am Leonard Wheeler, and this is the Prostate Playbook, Breaking Awareness. And look, there's so many things that we're going to talk about tonight, but before we get started, I wanted to make sure that you understand that there is a chat box, a Q&A, so you please feel free. I see some of you are already sending in questions. Thank you. Continue to pour in the questions. As you continue to bring them in, we will continue to make sure that we answer as many as we can. If we can't get to them tonight, we will make sure that we get to them at some point. But we will not delay on doing that. You will become our first priority, trust me. So let's talk about how brave you have to be to really continue to ask hard questions, because we know that the stigma is real. And so these are some of the things that we're going to talk about tonight. You're going to continue to hear some amazing stories. So let me introduce myself. My name is Leonard Wheeler. I am a TULSA patient and former NFL player. Dr. Scionti is a globally recognized leader in image-guided prostate cancer ablation, known for his pioneering clinical contributions and extensive experience in advanced prostate therapies. So let's talk about what we're going to be covering today. Today, we're going to be covering options. We're going to talk about what treatments are available for prostate conditions, what matters most when making a choice. Then we'll introduce the TULSA procedure, an option that prioritizes not only outcomes, but quality of life. And finally, we'll have a panel discussion where real men will share their experiences with prostate cancer as a TULSA procedure patient as well. So let's go to the next slide. So this is the handsome Dr. Scionti, which, like I said, you will be able to hear from him in a little bit. And let's go to the next slide. Let's give some disclosures. Dr. Scionti and myself, we are compensated consultants, and we both are here to share our personal experiences with the TULSA procedure. All information shared today is for educational purposes only and should not replace medical advice from your physician. So in saying that, I cannot delay any longer. The man, the myth himself, Dr. Scionti, take it away.
Well, thank you, Leonard, for a great introduction. And let's go to our slide here. So if you're dealing with prostate disease, what I want to tell the men out there is you are not alone. Did you know that 1 in 8 men in the United States will face prostate cancer? And 1 in 6 African-American men will deal with this, and it's even more common among veterans. Prostate enlargement, or BPH, is a universal problem with men. BPH affects, or prostate enlargement, BPH as we call it, affects about 50% of men by age 60, and by age 85, about 90% of men. Okay, so this is a very common condition. In fact, prostate cancer and BPH are the most common reasons men will visit their urologist. So we're here to help you understand your options for taking care of these conditions and help you make informed decisions. Let's go to our next slide. So let's talk about these common prostate conditions. Well, BPH, benign prostatic hyperplasia, or what we call a big enlarged prostate, is a non-cancerous enlargement of the prostate. As we said, it occurs in virtually all men as they age. Now, what symptoms will you have? Well, you'll see more frequent and urgent need to urinate. That is, going more often. The urinary stream often gets weaker, gets slower. There might be some hesitation to starting the stream, a sense maybe the bladder is not emptying, and getting up at night to go to the bathroom, sometimes 2, 3, sometimes even 4 times at night. So when we talk about prostate cancer, however, now these can coexist. You can have both enlargement and prostate cancer, okay? But prostate cancer is a cancerous or malignant growth within the prostate. Now, usually there's no symptoms at all to prostate cancer until it's very late in the disease. There may be some difficulty urinating, but usually the only sign of prostate cancer may be just an elevated PSA test. So these are things that you want to be talking to your doctor about. And if you're having your regular doctor visits with your primary care doctor, these are the type of things you want to be bringing up. So have a conversation with your doctor, with your primary care physician. Very important. So the key takeaway is pay attention to your symptoms and talk to your doctor about these things. Let's go to our next slide. Well, when it comes to prostate enlargement or BPH, there's a lot of ways to take care of this. It's very common simply to do some lifestyle management and manage fluids. There's certainly medications that have been around for many, many years to treat BPH. There's different types of implants into the prostate that kind of open up the prostate channel. There's different types of transurethral treatments, that is, treatments through the urethra, things such as, steam treatment or resume treatments you may have heard about, okay? There is certainly surgical procedures, either removing a portion of the prostate or the TURP procedure, or what we call the old sort of roto-rooter treatment, okay? So those are very common approaches. And of course, as we'll talk about in this presentation shortly, is TULSA or transurethral ultrasound ablation can be a very nice non-invasive approach for prostate enlargement. Now, when we switch to prostate cancer, one of the most common approaches for very slow-growing cancer is simply active monitoring, or what we call active surveillance. And for very small amounts of very early, very slow-growing cancer, that might be really appropriate, especially in our older men. Surgery has been a mainstay of treatment for many years. That is radical prostatectomy, or what's called a robotic prostatectomy. That's been around since over 100 years now. Of course, it's gotten a little better technique-wise, we hope, over the years. Radiation has been a mainstay of treatment, different types of radiation. You've heard about these things like CyberKnife or IMRT or seed implants. Cryotherapy refers to freezing the prostate, that is, putting needles into the prostate to create ice, and that can kill tumors as well. And of course, another type of ultrasound procedure is high-intensity focused ultrasound. Now, that's an ultrasound beam coming from the bottom up, that is, from the rectum up, or from the outside in. Very different than what we'll talk about is the TULSA procedure. Now, the right treatment for you really depends on the type of cancer you have, how much cancer is there, how active it is, and very important, what's the right treatment for you, and what's going to be important to you in terms of managing your cancer, maintaining your quality of life. So let's go to our next slide. So here we're going to introduce the TULSA procedure. This video animation will be really helpful to see what's going on.
The TULSA procedure is a new solution for men with prostate disease, including prostate cancer and benign prostatic hyperplasia, or BPH. It's a minimally invasive treatment that is incision-free, radiation-free, and performed in an outpatient setting, meaning patients go home the same day as their procedure. TULSA stands for Transurethral Ultrasound Ablation. Transurethral because the device reaches the prostate by entering the urethra. Ultrasound because ultrasound energy is used to heat the prostate tissue. And ablation because the heating is used to precisely destroy the targeted tissue. The TULSA-PRO system uses real-time MRI, which provides a clear image of the prostate, disease, and surrounding anatomy. TULSA-PRO offers a gentle heating pattern, which ablates desired prostate tissue while cooling the rectum and urethra. The physician can choose to ablate the whole gland or ablate portions of the gland, known as focal therapy. The TULSA procedure ablates the prostate from the inside out, from inside the urethra, heating outwards to the edge of the prostate. TULSA is an MRI-controlled, robotically driven procedure delivering 1 millimeter ablation precision to avoid critical structures and help preserve a man's urinary, sexual, and bowel function.
Okay, so now that we've seen the video, here's what you need to know about this procedure. So let's recap with TULSA. TULSA, again, most important, MRI controlled. Okay, MRI controlled, so real precision. We can see the prostate, we can see where the tumor is in the prostate, we can see the boundaries, we can see the neighboring structures, we can see the urethra. You can see the rectum. We can see the nerve regions where the sexual nerves are. There's no incisions. It's ultrasound energy from the urethra on out, inside out. It's robotic. So you've got high-tech AI-powered robotic approach. This is performed, again, in MRI suites. We've got real-time visualization, real-time temperature monitoring of the treatment. The ultrasound energy proceeds from the inside of the prostate outwards towards the edge with 1 millimeter of precision. It's a very gentle heating, but the computer tracks the amount of heat delivered to get what's called the proper dose to make sure the cancer gets treated. And here's the key. We're able to protect all the critical healthy tissues. Protecting healthy structures means maintaining sexual function, maintaining urinary function. Now, the TULSA-PRO procedure is FDA cleared. It was cleared by the FDA back in 2019, and there's been over 4,000 procedures performed worldwide. So this is a procedure that is going to be done on an outpatient basis, in and out on the same day. Of course, there's no radiation involved. There's no blood loss, and guys are back to their normal active lifestyle very, very quickly. So let's go on to our next slide here. So what can you expect? During the TULSA procedure, you'll be asleep. So it's really not scary because you have no memory of what's going on. The device that delivers the energy in the urinary channel, you won't even know about it. You're totally asleep under general anesthesia. Your care team will insert a very small, what's called the urethral applicator, into the urinary channel, the urethra, that delivers the energy. The MRI will be running continuously. Shows me exactly where the boundary of the prostate is when I'm doing this procedure. I can see where the structures are, where the bladder neck is, the sphincter muscle, where the nerves are. There's a very gentle, continuous energy that comes from the inside out to the edge. So this gentle heating over time accumulates enough dose to kill the prostate tissue. And of course, once you recover from your anesthesia, you're home within an hour or two of the procedure. Of course, there's the C word, there's a catheter involved, depending on the number of days, maybe up to a week or so, depending on how much of the prostate we have to treat. But here's the key. Guys, my patients, I did 2 of these procedures today. Both of the patients that we treated today, and within an hour, went home, and they're both out having dinner tonight with their family. So this is really a really revolutionary, minimally invasive treatment. So let's go on to our next slide. So here's the outcomes that really are important. If we go back and look at some of the published outcomes in our FDA trials, we know that urinary control continence, pad-free, diaper-free, 97% of men. 87% of men maintained excellent ability to maintain an erection. Now, in men who had BPH treatment for treating their enlarged prostates, 100% of those men maintained excellent urinary control. 94% of those men maintained excellent erectile function. And almost every one of these men got rid of their prostate medications. Here's the key to this whole thing, is that in your case, your results will depend on how much cancer you have, where the cancer is. But for a prostate cancer treatment, what the results we see were for whole gland ablations. Many times we're treating just a small portion of the prostate, what we call a focal treatment, and we see sometimes even better erectile function results. So these are the sort of things you want to be talking about with your physician. Talk to your TULSA specialist and see whether this option makes sense for you and for your cancer. Let's go on to our next slide here. And now we're going to move to the panel discussion. We're going to bring back Leonard and our panel to hear from men who have been through this treatment.
Dr. Scionti, thank you so much for all of that great educational information. Let me tell you, every time I hear you talk about that information, I get excited all over again because of the decision that was made to have the TULSA procedure over 8 months ago. I want to kind of go into asking some questions from the side, if you don't mind, just quickly here. How does the procedure, you feel, differ from the nanoknife procedure?
Okay, that's a great question. Nanoknife, or it's also called electroporation, uses electric current. So in the nanoknife procedure, a series of needles are placed through the perineal skin into the prostate. And the idea is to place the needles in just the right configuration so that electric current flows between the needles and basically kills the prostate tissue. Here's the problem. It's not robotic. There's no real-time imaging control. There's no MRI guidance. And there's no way to monitor the dose of electricity or what the effect is on the tissue. So yes, we've done some nanoknife work, but it honestly, in my opinion, it doesn't have anywhere near the sophistication I have when I do a TULSA treatment.
So what are the locations well, somebody asked what are the locations in Florida, and they can go to TULSAprocedure.com to see that, to see that information. There's a plethora of questions that I have for you. I want to make sure that we kind of share as much as we can with everybody. If you all notice, there are 3 other individuals that have joined us now, and I want to make sure that they introduce themselves, because we want to go into this panel discussion with these real men that had the TULSA procedure. And so I'm going to start with my friend Michael Vines. If you could introduce yourself.
Yep, Michael Vines, live in Charlotte, North Carolina, and had the TULSA procedure in December of 2023. And feeling great.
And then let's go to Ron Taylor.
I'm Ron Taylor. I'm 68 years old. I live in Dallas, Texas. And I've had the TULSA procedure actually twice. The first time in December of 2021 and the second time in January 2024. And my biopsy 6 months ago says I'm totally cancer-free at this point.
Awesome. Amen to that. Thank you so much. And then Dr. Philip Kell.
I'm 76 years old, and I had the procedure done in Florida. Sorry. Procedure done in Florida 6 months ago without a single complication.
And as you can see, Dr. Phillip is not too old to party. We heard your music, Doc.
That's right. Everything works according to original specifications.
Oh, well, thank you all so much for being here today. We have some amazing questions that we want to get to. And then we have the professional here, Dr. Scionti, that is going to continue to make sure that we're all honest, as he's going to continue to have our backs as we continue to ask some of these questions. Before Michael, I want to start with you. Before your diagnosis or your symptoms, what did you know about prostate health and the prostate disease?
Leonard, very little. I know my father had prostate cancer, and I went to see him and work him, support him through that. But very uneducated, very unaware, and just really thinking that was never going to happen to me.
I mean, Michael, you and I had a chance a couple of years ago, and we had a conversation about prostate cancer, and we had a deep conversation. What prompted you, or what happened for you to actually have to go and get checked?
Well, here's the value of an annual exam, right? So my doctor says, I felt something I don't like. You need to go talk to a urologist. Of course, I ignored that, just a footnote, just FYI, and said, yeah, she doesn't know what she's talking about. I had a colonoscopy, and then that doctor said, hey, FYI, I think there's something down there. You need to have a urologist. I'm like, okay, I guess I should pay attention to that. So it was a blessing that I guess it took 2 hits in the head to wake up. But anyway, that was how I discovered it.
Wow. So, Ron, men, sometimes we can be a little stubborn at times, right? I'm not saying you're stubborn. I know I can be a little stubborn at times. What prompted you to go get evaluated for your PSA?
I was pretty diligent in getting annual physicals, and my PSA level just kind of moderated around, and then one year it went up by about five times, and so my physician said, "You need to go see this checked," and referred me to a urologist, and went from there.
How many times did you say you were up at night?
That really wasn't a problem with me. I had no symptoms.
Okay.
I had some urgency issues, but no sign of prostate cancer until my PSA level rose so much.
So Philip, hearing Ron say that, isn't that sometimes what's so dangerous, right? Because we don't have any symptoms when it comes to dealing with the prostate disease. What are some of the symptoms, if any, did you have to prompt you to go get checked?
None. We've been tracking my PSA since I was in my early 60s. It'd been stable for 12 years, and then it started to rise slowly. And that's when I went and had the MRI biopsy, the full $1 million workup.
So Dr. Scionti, you've been doing this for a long time. What are some of the hard conversations that you feel that we need to have as men with one another when it comes to making sure we get our prostate checked?
We're guys, right? And men don't talk to each other about this kind of stuff really ever. Women do, but guys don't, right? It's hard to admit, as men, it's hard to admit there might be something wrong with you. You're 50, 60, 70, you feel great, you're in good shape. But the idea that you may have a cancer is scary. And the bigger concern, if there's a cancer, you've heard the horror stories about what that means. Okay, I'm going to be in a diaper, I'm never going to have relations again. So there's a lot of fear here. So the way you get over the fear is you talk to people, right? You understand that, it doesn't have to be that bad. A PSA can lead to an MRI, can lead to a precision biopsy, and it can lead to precision treatment, which means that, your life doesn't have to end because you have prostate cancer. And that's the message, right? Where guys get into trouble is they don't talk. They put their head in the sand, right? And then finally, maybe their wife makes them go get checked. And sometimes by that time, the cancer is much more advanced and a more advanced treatment is necessary, right? So it's fear, right? We're scared as guys and we tend to ignore stuff, right? We crawl back into our work world or whatever we're doing and we just ignore things. And so I think it's just a matter of, we got to have these conversations. When you're out in the golf course, when you're out with guys, you're in the barbershop, talk to guys, right? Bring this stuff up. A man should know his PSA number, right? We shouldn't be ashamed of that, right?
Awesome.
Women, they talk about their mammograms all the time, right? That's, but guys don't talk about this stuff. So I think the big thing is you got to get over that fear and realize it's not the end of our life. Prostate cancer should be a speed bump and not a car crash, right? We got to remember that.
Awesome. Thank you so much. So, Ron, what were some of the biggest fears that you had when you heard you could have prostate cancer? What were some of the biggest fears that came across your mind?
Leonard, unfortunately, I had a good friend who was at the final stage of his life as a result of prostate cancer. So my biggest fear is I ended up like him. And it was scary. It was really scary.
I hear you on that. So, Michael, you and I had a conversation about your wife playing a significant role and creating some great accountability when it came to you looking at options, right? You heard prostatectomy, and then your wife said, no, let's look at some different options. How significant of a role do our wives and significant others play in us as men when it comes to maybe looking a little deeper at other options?
Leonard, for me, it was critical because my reaction was, well, the doctor says he can take care of it. Just get it out. And that was all I needed to hear, right? It was like, let's just get this out because that seems like the logical approach. And she's thinking through, did you hear the consequences? Are you aware of what he's talking about? And I'm like, I just need it out. And she goes, well, hold on a minute. Let's do some research. And so then she went on the deep dive of exploration, which is, I'm so thankful she did that.
Wow. So, Philip, why did you specifically choose the TULSA procedure?
The various doctors taking care of me had 3 or 4 different opinions as to how it should be treated, and none of them mentioned TULSA-PRO. That was 3 urologists and a radiation oncologist. But I'm a physician. Medical research is second nature to me. So I was talking to people who were literally zealots for surgical total prostatectomy. I'd read all the same literature, and it was clear that TULSA-PRO was a viable option.
Yeah. So, speaking of options, Dr. Scionti, if you can answer this question for us really quickly. There are a lot of questions that are coming in, and they're asking the difference between TULSA procedure, HIFU. How would you answer that? Like by just telling them the difference between TULSA procedure and HIFU?
Yeah, no, that's a great question. I've got a ton of HIFU experience, 20 years of HIFU experience. And so in the right patient, it's a fantastic treatment, but they're different. So, HIFU is a treatment in which the energy comes from the rectum through the wall of the ball up into the prostate. And there's limitations of how far that sound energy can go. So certain parts of the prostate are totally inaccessible to the HIFU beam. When we do a HIFU procedure, I don't have quite as much precision because we're using an older MRI that's registered or fused or married to an ultrasound image, but we don't have that real-time MRI guidance, nor do I have true real-time temperature, monitoring. So, in the right size prostate, that has, especially where I have to treat a significant portion of the prostate, I'm going to get a lot more precision with TULSA than I'll get with HIFU. So it really comes down to, you can't have a one-size-fits-all approach when you talk about any treatment, and especially if you're an ablation specialist using energy, we got to know the different energy sources and what's most appropriate. But I would say that compared, some patients with small posterior tumors that are easily well delineated out at the edge of the prostate, HIFU is going to work great. But I had a gentleman today who had a tumor that draped across the whole top of his prostate. The HIFU beam would never reach that area. And so TULSA was a perfect solution. So it comes down to an individualized, personalized approach for every guy.
Okay, awesome. Thank you so much. So if I could have everybody share your PSA, I'll start. My PSA was a 3.1, and the reason the doctor was concerned is because I had a trend over 3 years that went from 1.1, 2.1, and 3.1. So even though it wasn't a threshold, there was a trend that was being expressed at that particular point. So let me go around and ask everybody what their PSA run. What was your PSA?
Right at 8.
Right at an 8.
Uh-huh.
Okay. And when you had the conversation with your physician and he saw it was an 8, what was his first response to you or respond to you?
We need to get you into a urologist. And so I did that. And that wasn't a good experience because the urologist I was referred to gave me no confidence in where we were headed. And that put me on my wife really on Michael's wife's quest of, you're not going back to that urologist. We're going to go deal with this. And found the hospital I went to, and they offered TULSA, and that's how
that was it. So that's important too. And we're going to come back to that because it's important to make sure that when we identify someone that they're also not all created equal, right? To where,
sure.
So we have to make sure that we do our research when it comes to that to make sure that it's a perfect fit for where you are and what you need for you and your family. Dr. Phillip, what was your PSA?
8.
Okay, so you're trying to be like Ron. Okay, I understand that. So what was your first response, your physician's response when he told you 8?
Well, I got into the hands of a couple of zealots.
Okay.
And they were truly unprofessional in the pressure they tried to put me under. And I'm a physician. They can't BS me. And they just wanted to operate. There was no discussion about anything else.
So in other words, we need to make sure that we understand that people are going to have their own agendas, right? And so it's important for us to make sure that we understand what we're to stand on when it comes to information and doing the research for ourselves so that we can learn to ask better questions. Michael, what was your PSA?
So I peaked at 3.7 in January 2023. That was the height of it, 3.7.
And so at a 3.7, did the doctor then say, hey, we need to make sure we dig a little deeper? Or did he say, do you need to surveillance it?
Well, the recommendation was, let's do surveillance. But then they also wanted to look at the genotype, and I may not get the language right, but basically the makeup of the tumor. And the outcome was it was sort of an angry tumor that, based on how you're made, surveillance may not be the best option for you based on what the tumor could end up doing. And so, we were definitely, the surgery was an option, but we were sort of leading down the surveillance road until the results of that genotype came back, and it was like, I'm not sure that set my wife on a new quest because it's like, well, okay, so that may not be a tumor that we want to just let hang around.
Understood. Okay. So there's so many questions that are wanting to be asked right now. I'm really trying to cover as many as we can, everybody. Thank you so much for your patience. Earlier, somebody asked about the reoccurrence rate when it comes to the TULSA procedure. Ron said that he's had it twice. So Dr. Scionti, what is the reoccurrence rate when it comes to the TULSA procedure?
Okay, so it depends on whether the whole prostate's treated or a partial or focal treatment's done. So in the case of a focal treatment, which means there's cancer in only a region, you're treating just the bad area and you're observing the rest of the prostate, you can have recurrence of the site where the cancer was, or you can develop a new cancer in an untreated part of the prostate. So those are two different issues, right? But if you talk about the ability to kill the known cancer, the clinical trials show that, when you look at large numbers of men and they all get rebiopsied, 7 out of 10 times the cancer is completely eliminated, and the significant cancer is eliminated 8.5 out of 10 times. So, which means that the significant cancer can exist about 15% of patients after a single TULSA treatment. Now, that's very similar to what we see in our guys who have radiation who have a prostatectomy. The numbers aren't terribly different. Some men who have a focal treatment, they've got the same, 1 in 8 chance that in the healthy prostate, as time goes on, they'll develop some cancer elsewhere. The nice thing about TULSA is it doesn't burn any bridges in terms of having secondary treatments. All the treatment options will still be on the table. So the reality is, if no matter how you're treated for prostate cancer, you're going to be followed carefully. You're going to look at your PSAs. You do periodic imaging scans. I think MRI is a beautiful way to follow this. And you may need additional therapy. It's easy to say, I'm done, I'll never look at this again. But we follow our patients long term, right? And as long as we do that, right, if there's any recurrence, you catch them early, you deal with it in the most appropriate way. But here's the key. Every step of the way, we've got this decision to make about treat, observe, treat, maintain quality of life. And you get on that road and you follow that balance. And the goal is that, we'll all live to ripe old age and die of something else. And we'll maintain our functionality throughout our natural lives.
Well, look, thank you all. So, I know that a lot of this information can be overwhelming. It's like drinking through a fire hose, right? Because there's so much to unravel here, because this procedure is life-changing. I mean, I believe that the TULSA procedure should become the gold standard personally. Because I remember after I had the procedure, I went to our VRBO, and my wife and kids, they had to have a come to Jesus meeting because they're telling me to sit down. I can't unload the truck. I can't help with the luggage. I have a catheter in. I just literally had the procedure, and I'm like, I feel like I can, that I can unload some stuff. Let's go. And so that didn't seem normal, right? So when you think about how you found out about the TULSA procedure, Philip, how did you find out about the TULSA procedure?
I just started what I used to do as a medical student. I started researching the subject, and I went from paper to paper to paper. Now you can do it more easily on YouTube, but it's not like going down to the library, because we have to. But it's just a matter of working at it and working through the numbers and working through the misinformation you're getting from some physicians.
That's awesome. So, Michael, so you had your catheter in. Obviously, there's a catheter that's going to take place after the procedure. What was your recovery time from the time you had the procedure to when you started feeling decently normal? What was your recovery time?
Well, after a few days, you're sort of back to normal. It's just strange. You got to wear a bag strapped to your leg to go to church, right? That's sort of the weird thing, right? But can you go to church? Can you go to dinner? No, you can't work out. Got that. But, the fundamentals of living life were fine. You have to get used to wearing a bag around. And, but, that's just, here's the deal. Like your brain, you just have to tell yourself, this is a short-term problem. This is going to end. There's a countdown. It's not like, this is like a 14-day countdown, and every day you just celebrate. And it's going to end. And guess what? It ended.
So that's a great point, Ron. When I heard Michael say it's about mindset, it's about kind of shifting your belief system around it. Tell us what your experience was like. I know that you said that, you were able to kind of get out there and walk around and do what you were big and bad enough to do. When did you start feeling normal, Ron?
With the exception of the catheter, within a day of the, I took Tylenol is all I took. I kid with my wife. I can tell you where my prostate is because it didn't hurt. It just I knew it was there. So within a day or two, absent the catheter, life went on. I was working. I was, like Michael said, active with the family and doing normal stuff.
So earlier, Doc, we talked about incontinence. We talked about erectile dysfunction. We talked about real life issues, real fears that men have when it comes to having those discussions, and it's just the sexual functions, right? So just when we talk about the overall sexual function, when it comes to all of those issues, what are some of the conversations that we need to make sure that we're having as men with one another or if someone's dealing with it and I've dealt with it, what are some of the conversations that I need to make sure that I'm having with other men?
Well, it's a hard topic because guys don't like to talk about this stuff, right? So how many guys, want to say, well, who wants to admit that they have erectile dysfunction, right? Who's going to, so that's a tough thing. But here's the reality is that, if you've got prostate cancer, you got to deal with it. You're going to have to address it because every treatment, it's going to be part of that decision, right? So, and once you open up to guys, they'll talk, right? They'll share their experiences. You just sometimes have to, say, hey, listen, I've got prostate cancer. I'm really, I know have you ever dealt with this? What do you heard? I'm afraid of the sexual consequences. And guys will talk. You just got to be, you got to open that door and sort of make yourself vulnerable to get involved in the conversation, because it is a scary thing. Because think about this, you're perfectly healthy, your life's going great. Someone does a PSA, a couple of weeks later, you're given a cancer diagnosis, and then you're saying, okay, what's this mean? How's my life going to change, right? Everything is going to, and everything can end, and in terms of life as we know it, and that's scary. I think you get through it by talking to guys, especially who've been through it. And so I would say for anyone who's been diagnosed, talk to men who've been through different treatments. If men are thinking about TULSA, talk to guys who have been through TULSA. Talk to guys who have had a prostatectomy. What's it like? What's the experience like? Are you having erections? Are you having relations again with your wife? How, is it possible? These are the kind of things you got to ask. And guys who have been through it are usually pretty happy to talk about it and share their experiences.
So talking about that, when you think about the sexual functions, let's stay there for a second, and you think about the TULSA procedure compared to a prostatectomy or a radiation, etc., how does the TULSA procedure compare when it comes to those sexual dysfunctions to prostatectomy and radiation?
My job isn't to try and sell anything to anybody or convince someone, but I would say honestly, there is no comparison. There's no comparison, absolutely none, because there's no way, and I'm trained as a surgeon, there's no way we can take a prostate out robotically or an open procedure, and there's no way not to cause some injury to those delicate little nerves that are right along the back side of the prostate. There's no way. It's going to happen. And so some men will recover eventually some erectile function after surgery. Sometimes the younger they are, sometimes they do fairly well. But I tell you what, it's not reliable, it's unpredictable, and even in the best surgical hands, we see significant ED. And my TULSA patients, unless we had to be really aggressive in certain cases around the nerves, they're going to have erections the minute that catheter comes out. And they may not be perfect by 3 to 6 months out. The research shows that 90% of men are back to their baseline ability to function. Now, I can't do that for a patient with anything else I know.
That is a true statement, because I almost had to tell my wife to wear pajamas for those 2 weeks I had my catheter in. I'm just saying. So I have a question for you. There were some questions around 4+3 around the scores when it came to the biopsy. Do you all remember your numbers? I know I was a 3+3, 3+4. Michael, Ron, and Philip, do you remember your numbers when it came to your scores?
I do.
I had, of the 12 cores, 3 were 3+3 and 1 was 3+4.
Okay. And Ron, what was yours?
They were all 4+3. I had a couple 3+3s after.
Okay.
They only did a partial ablation on my first one because they only knew of one lesion, and then the second one. So the second one, there was 9 samples taken, and all of them, with the exception of where they did the first ablation, all of them were positive, and they were 3+3s or 4+3s.
Okay. Michael, what was yours?
3+4s, I'm pretty sure.
So, Doc, talk about the significance of those numbers, if you don't mind, so that our listeners, our people that are watching, can kind of understand what those numbers represent.
So they represent something called the Gleason score. And basically, it's a scoring system that's been around for 70 years. The pathologist looks under the microscope at the size, the shape, the pattern of the cells. And there's 3 patterns. There's pattern 3, pattern 4, and pattern 5. The most common pattern they see is the first number. The second most common pattern they see is the second number. So a 3 plus 4 means there's more of the type 3 than the type 4. If there's a 4 plus 3, there's more 4 than the type 3. The significance is that the higher the number goes, the more biologically active the cancer is, the more aggressive the cancer is, which means that, if the cancer is has a greater chance that it can spread, more chance that cancer can recur. But guess what? That applies no matter how we treat the disease. If you've got a 4 plus 4 cancer, whether it's radiation, surgery, HIFU, TULSA, no matter what's used, the cancer's got a higher chance of coming back. So I don't use an absolute Gleason score cutoff in terms of who I'll choose for treatment. I want to know tumor size, tumor location, what the tumor is near, how big the tumor is. Can I see it? Can I get to it? And I think those factors become more important than just a biopsy that says I've got a 3 plus 4 or a 4 plus 3.
Okay, that's awesome. Thank you so much. I'm sure a lot of our listeners got a lot out of that. So I want to ask some questions just quickly here. Michael, I want to bring this one to you. What advice would you give men who may be avoiding prostate conversations and screenings right now?
Well, I would say that would be a big mistake. One of the biggest challenges to overcome in life is regret, right? And so, to avoid that may lead you to a day of great regret because you can't undo time yet, right? We can't fix that. So not taking that on, the cancer isn't going to the cancer doesn't take a vacation, right? It's going to just do its thing. So when you don't address it, you're giving it a chance to take over. So don't allow yourself to have this regret that you're dealing with. If I only would have, that is the wrong answer. That's a tough answer to say, if I only would have. By the way, time is more valuable than money, right? So sometimes people say, well, I'm not going to spend $1,000 on this. I'm like, okay, let's just think about the cost of that decision. It's an important to understand how time and money work together. And anyway, those would be my thoughts, Leonard.
No, that's great. Thank you so much. I'm going to send this one to Ron. Ron, for someone who is newly diagnosed, what would you tell them about exploring their options and advocating for themselves?
I think you just have to come to where you're comfortable. My wife was diligent. She was on me all the time. But we had the privilege of going to UT Southwestern here in Dallas, and I remember my first meeting there, the doctor said, "You've got cancer. I almost guarantee you." This was before I had a biopsy. And the sooner you get your head around that, the sooner we can treat it. And then they provided me with consultations of many of the procedures that were listed that Dr. Scionti's talked about. And I met with 4 different professional groups down there. And at the end of that, I had the privilege of saying, I'm most comfortable with that. I think it provides me this quality of life that I really seek. And if I fail, we'll do it over. That was a big thing to me. And in retrospect, that came into real play in my life. So
that's awesome.
Just go where you're comfortable. Follow your gut.
Thank you. Philip, what do you want men and their families to know about taking charge of prostate health?
Say again.
What do you want men and their families to know about taking charge of their prostate health?
That there's a great deal of disinformation, and people have agendas, and that they need to research the whole thing and talk to more than one person. I am a pediatric cardiac anesthesiologist. I've spent my life, my professional life, ignoring what surgeons say and want to do. My job was to protect the children from the surgeons. And that's what I had to do with the surgeons that tried to get their hands on me. So
Wow.
you've got to get it. You've got to talk to more than one person.
Yes.
And you've got to read. Now, there are some excellent sources on YouTube that provide good information. But there's also a lot of people that don't.
Yeah. I would say that I think it's important to make sure that you don't feel obligated to anyone when it comes to, having surgery. You're obligated to yourself and to your family.
That's right.
That is who you're obligated to when it comes to having a procedure, right? And so, Dr. Scionti, there was a couple questions here. What about calcifications? Can they still have the TULSA procedure?
Yeah, it depends on where they are. Okay. Calcification, you've heard of little stones that form in the prostate. And here's the rule in physics is sound waves don't go through stones. They bounce off rocks. So if in the pathway of where the sound has to get to, there's a calcification, then the TULSA procedure is not going to work. But if there's a part of the prostate that needs to be treated, and it's a targeted treatment and there's no blockage in that area, the TULSA procedure will be fine. So it's about knowing exactly how big they are and where they are and see whether it's going to interfere.
Okay. So there were some questions around radiation as well, in terms of, dealing with BPH. If a person has a pacemaker, can they have an MRI?
So a diagnostic MRI, can be accomplished in a case where there's, a more modern pacemaker, right? So the very modern pacemakers, especially at a 1.5 Tesla MRI, a diagnostic prostate MRI can be done in the right setting, but you got to have an MRI compliant pacemaker. The newer ones mostly are. You got to read the labeling or the little card that comes with the pacemaker, and certainly ask the MRI facility, because they can go to a registry and they can plug in the model of your pacemaker and know whether it's compatible or not.
So all of us have been through the TULSA procedure. We know that the heat kills prostate cancer cells, but why does it not kill the urethra cells, Doc? That's impossible.
Because we keep it cool, right? The sound, it's like a radiator, right? You have an internal cooling radiator in the urethra. As energy passes through the area, you've got a zone of cooling, of thermal protection, and that's what protects the urethra. So it's simple physics, right? That's one of the benefits of TULSA is that because you can cool the urethra and pass energy through a cool zone, right? And that zone of coolness is about a 5 millimeter zone, right? Once you get beyond that, that's where the heat accumulates.
Well, I can tell you all right now that I'm here in Toronto at Profound Medical, and I've been able to go through the procedure and go through the entire building and look at the boots on the ground, and these people impress me beyond anything I can even converse about, because I'm seeing how it's being manufactured and it's blowing my mind. The science behind it, the math, the precision, the efficiency, it continues to overwhelm me, because I'm going, oh my gosh, all of this was created so that we are all having these conversations on the Zoom on this deal tonight. And we're breaking the silence. So I can't even imagine how many lives are being changed because we're breaking the silence as men talking about this conversation right now. And so I can't even thank you all enough for all that you continue to do and the time that you're spending on this webinar tonight with all of us. I know that we have over probably 300 people on the webinar tonight listening, and the impact that we're creating is going to continue to be sensational. So I want to end with a quick question to all of you before we end. So are you all ready for this question? Okay. What scares you the most now when it comes to where you are? Let's start with Michael.
Leonard, just honestly, realizing I'm not in control of my life tomorrow, when I realize that, recognize who is in control, fear can go away. And if it comes, if cancer takes me, but I've got a better place to go to, and I'm not going to let that fear, it doesn't belong. I'm just going to say no. And so I'm not afraid of the future. I can't control it, but I'm going to trust the God who does.
That's awesome. Thank you. Ron.
I don't have fear because the procedure was just wonderful. I remember sitting in a parking lot and reading my biopsy in March of earlier this year, and just being filled with such gratitude because all 12 biopsies were negative, cancer were benign, and the gratitude I felt. So I really don't fear it anymore. I don't live with a lot of fear. This was fearful, but through grace and the wife's diligence and some optimism, we found a person who took care of that in a way that has been just marvelous and wonderful. And I'm just grateful that happened in my life, and I'm optimistic that whatever comes next will conquer it the same way.
Wow, awesome. Philip.
I have no worries at all. I have a great deal of confidence in the procedure, the team that took care of me, and I'm almost 77. So a lot of people, and I'm English. In England, they probably wouldn't even do a PSA.
Right.
They don't. They consider the psychology of discussing it more damaging than ignoring the cancer. So I've nothing at all. And I would mention that, because I think it is important, at age 76 and a half, my wife and I resumed sexual activity at day 21.
Let's go, Philip.
So, and that was the biggest fear. Dying didn't bother me. Impotence did.
That's good stuff. Thank you. So before we get to the next steps, taking the next step, I think it's important to make sure that, you all heard all of these men talk about their families, because it's not just about us by ourselves, but we have people that love us, that care for us. And when I think about my wife and our kids and my parents and my friends that came over and prayed with me before I went and took the procedure, and I think about Dr. Bush and Kathy Bush, and I think about all the people that played a significant role in us being here. And I think about Tom Tamburino and Arun and LV and, Kimberly Lovey. There are a lot of people that I think we need to make sure that we're continually celebrating when it comes to us still being here and being able to have these conversations, is because someone believes in something bigger, right? Someone believed that they could create something that could make a difference in people's lives, and that could prolong activities when it comes to sexual functions. And so I just think it's important to make sure, and I'm sure that we all do it, but I want to make sure our listeners and the people who are watching are also making sure that you're celebrating those moments, that you have those precious moments that the Lord allows us to have and to celebrate at home. I want to just talk about taking the next step. If you say yes to any of these TULSA procedures, the TULSA procedure might be right for you. So I'm going to ask some questions. I have prostate cancer or BPH. The next one, I want to avoid surgery or radiation. Radiation was not in the cards for me. So that was not an option. But I had already scheduled a prostatectomy, and I was a week from the schedule when I went and had the TULSA procedure. And then the next one, I care about preserving my bladder, control, and sexual function. If you want to check that. And then I want a fast recovery. If you check those things, the TULSA procedure is the right step for you. I'm not the doctor, though. But let me tell you, Dr. Scionti is. And Doc, off of what I read, don't you agree or do you not agree with what I read in terms of next steps?
No, I think you're absolutely right. I think anyone who's got the diagnosis of prostate cancer, or in fact dealing with a very large prostate, I treated the patient today with a prostate 120 cc's, huge. I mean, anyone that's dealing with I think you have to look at your options. You have to consider them all. And the list doesn't end with surgery and radiation. There's more to it, right? And so, yeah, you may be a great candidate for TULSA. I think every man deserves to know what all his options are and see what the right fit for his cancer and for him and his family is going to be. So, yeah, I think if you're in that category, yeah, you got to take a look and do yourself a favor and look at all the ways you can take care of these problems.
That's awesome. So if you can see, you can scan the code here that is on the screen, and it will take you to the patient consultant, to where it'll literally bring you to the TULSAprocedure.com website. And then you can consult, you can do a patient consultant once you click on it, and you'll have somebody reach out to you in no time. Let me see here. There's a little bit more information. Yeah, you have to, so you have to fill out the form, and you have to fill out the form when it comes to that information. And so let's see here. Let's go to the next slide. And make sure that you pay attention to the risk and safety information when it comes to this, okay? Just like Dr. Scionti said earlier, is that the whole prostate journey is a customized journey. Everybody's gonna be in a different set of mindset, a different place physically, and that journey is gonna be different for everybody. So just make sure that you are consulting the correct people. You heard from Ron when he said he went to a urologist that was not the right fit. And the result of that is he had to go in and have it done again by someone that was the right fit. So let's go to the next slide. Is that it? Mm-hmm. All right. So again, this is the scan. For everybody to scan if you want patient consulting. And I am so grateful and thankful for Dr. Scionti, Michael Vines, Ron Taylor, and Philip Kellett. You all are amazing men. Thank you so much for having the courage to be able to put your information out there to so many other people to change their lives. I'm Leonard Wheeler. Thank you to Profound Medical. Thank you to the entire team of Profound Medical. You all are amazing, amazing, amazing. What's that? And thank you all so much for your time tonight. We can't do it without you. So hopefully, if you have any other questions, please feel free to reach out. And as you have filled out information right here, I see Mr. Silverman here. We'll make sure that we get back to you as soon as we can. So God bless you all. Thank you so much for your time tonight. I appreciate it.